I would like to invite Dr. O.C. Abraham to moderate the next talk titled Equitable Care for Visceral Leishmaniasis in India by Dr. Shyam Sundar.
Good morning, friends. It's my privilege to introduce the speaker, Dr. Shyam Sundar. Dr. Shyam Sundar is the Distinguished Professor of Medicine at Banaras Hindu University in Varanasi. He's an alumnus of the same institution, has spent his entire professional career in BHU. To most audiences in India, Dr. Shyam Sundar does not need an introduction. You know that Kala-azar or visceral leishmaniasis is primarily a disease of poverty, affects the less fortunate among us. And more importantly, treatment of this condition is one classical example of a catastrophic medical expenditure. But the good side is that this is a disease which can potentially be eliminated. And if there is one individual, if elimination of Kala-azar becomes a reality in India, and if you want to name one person who is responsible for that, that is Professor Shyam Sundar. So advances in diagnosis, you'll hear more about it. Advances in therapy, which make this dream possible. We know we have last mile challenges, but Dr. Shyam Sundar will talk more about it. Talk to us more about it. So over to you, Dr. Shyam Sundar.
Thank you, Osi. Thank you for the invitation. So just to shortly introduce you the parasite, promastigotes are usually found in vector, which is Phlebotomus argentipus. Okay. And the amastigotes round figure without flagella are found in host, in human host. In India, the transmission in anthroponotic means sandfly vector and then to human being and then again from human being to sandfly and then it goes on. Zoonotic, there is a animal reservoir also. I'll skip through this slide and come to the leishmaniasis. There are three forms of leishmaniasis: visceral, cutaneous, and mucosal. Visceral leishmaniasis is caused by Eldonovani in Asia and Africa, whether it is anthroponotic. And in zoonotic, the reservoirs are dog and again in Europe and South America. These are the dark colored, these areas are the endemic zone for three endemic zones, India, Indian subcontinent, Africa, and South America, mostly Brazil. Earlier, India used to contribute to almost 2/3 of the patients of the world of leishmaniasis. Now the situation has changed. I'll soon tell you. This is a picture from a typical picture from an endemic area where you can see a lot of straw houses, mud plastered houses, which promote the growth of sandfly. Then there are animals who are also responsible for the growth of sandfly, and then young children who will become victim of this disease. It's epidemic endemic in 80 countries. Population at 1 billion. Incidence per year is 30,000. And as I told you, Bihar adds most of Kala-azar cases in worldwide. This is a Times of India headline in 2014. And these were the numbers. If you see these numbers, you will notice that the number of cases varied from about 20,000 to 77,000, and these are not real figures. There is a gross underreporting and 5 to 8 times underreporting. So actually these numbers are in hundreds of thousands at that time. Clinical features are basically fever and splenomegaly. And splenomegaly is remarkable. There can be pancytopenia and consequences of pancytopenia, like bleeding manifestations and anemia and other things. It causes immune suppression. So patient is prone to develop secondary infections. Pneumonia is one of the important disease, which is the most important killer. Then tuberculosis, herpes, and GI infections. The important thing is that if you don't treat these patients, they are going to die. This is one picture of one of our patients, where you can see the huge spleen occupying the abdomen. The diagnosis usually is by parasite demonstration. So splenic aspirate has got a sensitivity of 90%. Splenic smears. Bone marrow 60 to 85%. These are invasive procedures. You can and you need really a lot of skill if you are doing a splenic aspirate, because you can cause internal hemorrhage and you will not be able to do anything about this, and patient may die in front of you. So one has to be very careful. And this is how splenic aspiration is being done in this section. And this is a picture of the parasite, where you can see one macrophage is there, big macrophage, and there are numerous amastigotes. And the important thing is that you will get 2 dots, one big dot. If you carefully look into the say this amastigote, you can see this is a nucleus and this is the kinetoplast. So these two are very hallmark of this amastigotes, and I don't think anything else occurs like this in our medicine. Serodiagnosis again has been developed, but I think there is a wrong slide.
Which one, sir? This one. This one?
Oh. Yeah.
I'll just open it again once.
Sorry for the mix-up. This was my previous lecture that I gave in training. Yeah. So I've already covered this. So infection risk is related to poor housing conditions. The vector I have already told you breeds in cracks, and the total cost of treatment of one visceral leishmaniasis patient exceeds their average annual per capita income. So the patient party, they have to sell their houses, sell their all the properties to treat these patients. though the global incidence of VL is lower than HIV, malaria, and tuberculosis, the social and economic implications are that to the affected community is profound. It really changes their life. Thank you. To prevent and eradicate visceral leishmaniasis, diagnosis and treatment for such a deadly disease need to be subsidized or provided free to the majority of the patients. You can see this is one of the picture where you can see the brick unplastered brick house, the animal living with the patient, and these unplastered brick house also promote growth of sandfly because of the crevices that they have. Another picture you can see again, the straw houses, unplastered houses, walls, animals. So they live all in close vicinity, which promotes the growth of sandfly, the vector. Now, what are the challenges in ensuring equitable care? Lack of awareness. Most affected people, most of the population in rural areas are not aware of the disease and its implications. And this delays the diagnosis and treatment. Actually, patient goes from one doctor to other one, and then takes a lot of time to reach to the right place. And these patients come from remote areas. So there the medical facility is very limited. And in the areas endemic for this disease, there is a poor health infrastructure from where, and they might not be well equipped. Wherever there are primary health centers or CSC, community health center, they may not be well equipped to diagnose and treat these patients. So what are the challenges? Cost, treatment is expensive, hard to afford, I already told you. Stigma associated with, especially with post-Kala-azar dermal leishmaniasis, patient can face stigmatization leading to hide their condition or avoid seeking care. They may be ostracized. I remember one patient of PKDL who had nodules, and he was, outcasted by the society. And then overall, the drug resistant developing in some of the pharmacological agents are complicating the treatment. I mean, this picture already. So what should be the strategies for equitable care? Community awareness program. So widespread campaign and, making these public aware of the area of the places where detection and treatment can be done in local languages or in the constructive and cultural context can make these more effective. Visceral leishmaniasis basically is a rural disease. Most patients are from far-flung areas. So to provide them care, equitable care, we have to establish diagnostic and treatment centers in high incidence areas, right in the heart of the endemic areas. The strategies, subsidized treatment, so the government and NGOs can work together to bring down the cost of treatment, making it affordable to everyone. And then, of course, research and development is needed, and research for better diagnostic tools or treatment is very important of paramedical. An effective vaccine, there is no effective vaccine at the moment. And then understanding drug resistance and ways to avoid it, circumvent it. Essential component of VL management, again, regular surveillance, regular monitoring can help in understanding the disease spread, identifying new cases early and ensuring that patients complete their treatment. The stigma has to be removed. The people have to be made aware of the disease. And I mean, most commonly, these patients are, especially of post-Kala-azar dermal leishmaniasis, they are confused with leprosy. And leprosy has so much of a stigma. So I think we have to address that. Then, of course, collaboration is a must. Collaboration with the government, with the both state and central programs, national programs, NGOs, and so to share the knowledge and best practices. Vector control, of course, reducing the population of sandflies is of paramount importance if really we want to eliminate or eradicate the disease. And this can be done through insecticide-treated nets, indoor residual spraying, and environmental agents. Diagnosis of VL. About 2 decades back, establishing a firm diagnosis was difficult and expensive. I already told you in the previous presentation. And it depended on the parasite demonstration. And other modes like bone marrow, the sensitivity is low, and I already told you about the danger of splenic smears. The facilities for these parasitic methods to detect parasites is limited to big cities, and that to 1 or 2 places. And hardly anybody, I mean, there are very few people who can do splenic aspirate. And then not only that, it is very expensive, 500 to 1,000 rupees per test, which is a big money for these people. And another thing is that it takes several days. The patient keeps on moving for diagnosis. It doesn't only harm the patient, but it also harms the community, because we have shown in one of our paper where we found that one of the most important source or reservoir for the sandflies was patients, active patients. And of course, the diagnostic tools were not very robust, so the misdiagnosis was common. I showed you this. So in 1998, a rapid test was developed with one of our colleagues in US, and we reported a very high sensitivity, almost nearly 100% sensitivity, and slightly lower specificity. The beauty was that you can use only 1 drop of blood and get the results in 10 to 15 minutes. Of course, now you'll be pleased to know that it is available free of cost for every patient in public health delivery system. And of course, it is also available in private diagnostic center. The cost was about $1.5. But of course, the private people, they will not settle less than 500 to 1,000 rupees. This is the strip that you can see. The lower 3 strips have 2 lines. One is the upper one is a test line. The upper one is a control line. The lower one, in the 3 lower strips, you can see there are 2 lines. The lower line suggests that this patient has got anti-K39 antibodies. Then, what is inequity in the treatment of visceral leishmaniasis? Resistance to the drugs. I mean, today or a few years ago, I mean, there was a huge population of patient resistant to sodium hexagluconate or pentavalent antimonials. There is nobody is interested, whether pharma or academia, to work on this disease, which is, again, the returns are not there. The economical returns are not there, so hardly anybody is interested. We did a study way back in around 2000, where we found that only 1/3 of the patients are responding to antimonials. So really we need a new drug. And of course, this drug causes serious cardiotoxicity and death also. As you can see in this slide that initially the cure rate with antimonials was 96%, and slowly over the period, even after increasing the dose to double and duration to 3 times, 30 days, 20 milligram per kilo, the cure rate is 35 to 45%, and which is a dangerous or very alarming condition. Now, what had been the impact of antimony resistance? More than 95% of VL patients' daily income is $2 to $3 if they are able to earn it. Many will not be able to earn even then. SB or antimony was the only affordable drug which would cost, the treatment cost will be around 1,000 rupees. But these people cannot afford, and even 1,000 rupees is much more money for them, and above that is simply impossible. And I already told you what a delayed diagnosis can do. In the year 2000, the National Expert Committee decided that because of the resistance of antimonials, amphotericin B should be the drug, first-line drug to treating VL. The problem is with amphotericin B oxycolate treatment is high cost of the drug, use restricted to the hospital because the patient has to be there in the hospital for 5 to 6 weeks. Infusion reactions are universal, high fever, rigor, chills. Anybody who had used amphotericin deoxycholate will know that it really causes infusion reactions. And then if patient is lying in the hospital for 5 to 6 weeks, there are others who are waiting and you have limited bed capacity. So there is a waiting list and many die or died waiting for the treatment. And of course, you have to monitor the treatment. And so finally, the gist is that amphotericin B deoxycholate could not be implemented. It remained in the hands of few hospitals. Otherwise, it was not accepted by the, or not used by the primary health facilities. Then perimomycin was another drug. This is a aminoglycoside. And this was known even early 90s that this drug would cause cure of 93% patients at 16 milligram per kilo intramuscular injection for 3 weeks. Then it took several years, almost 15 years, to find funds to do a pivotal trial where this drug could be, registered or approved for. It was not approved at that time. It was, or it is, in fact, the cheapest anti-leishmanial drug. It is made in India by Gland Pharma, Hyderabad. And these drug, India-made drug, is used extensively in Africa and other parts of the world. However, again, there is a pathy. So non-availability of this drug to Indian people is a matter of great concern. And I failed to find the reason for that. Then we have been looking for oral anti-leishmanial drugs. And we failed with many drugs, ketoconazole, fluconazole, atovaquone, sitamaquine, then multiple drugs. Then we came across a very effective anti-leishmanial drug, miltefosine, which was actually developed as a new anti-neoplastic agent in Germany. So we tested oral drug miltefosine in a dose escalation trial, and where we found that 100 to 150 milligram of miltefosine given for 28 days would cure more than 93% patients. And then finally, a phase 3 trial was done, and it was confirmed that this drug would cure 94% patients. And then this was approved. This drug was approved. I forgot to tell you that perimomycin is also registered in 2007. It was registered for treatment in India. So the oral drug with ease of administration is very attractive to the National Health Program or for anybody, in fact. And its use in field was easy. There are several shortcomings with this drug. Most importantly, it has to be imported. The cost was prohibitive, and there was only one manufacturer in the world. It was patented at that time. Then in 2005, India, Nepal, and Bangladesh, they joined hands to launch an elimination program with a target to bring down the incidence of VL less than 1 per 10,000. And the component was early diagnosis by K39 strips, treatment with oral miltefosine, and then, of course, vector control and health education. And these diagnosis and treatment would be free to everybody. What was the problem with miltefosine? 28 days treatment, really non-compliance is going to be very common. We forget to take 5 days antibiotics. So you can imagine 28 days. So that was a problem. It was a potentially teratogenic. So 5 months contraception is required for a childbearing age group. And then there can be sometimes severe adverse event, but very rare. And it has a long half-life, so very vulnerable to development of resistance. Then came the lipid formulations of amphotericin B. It was one of the most exciting development, and it was not because of the Leishmaniasis. It was because of the fungal infections in HIV that these lipid formulations were done. So don't be, don't be fooled that this drug was developed for it was for that. But the good thing about this is they were very safe. You can give large amount of drug in a single day. Whereas in deoxycholate or amphotericin deoxycholate, there is a limit. Most people will not use more than 1 milligram per kilo per day. The problem was again highly expensive. At that time, 50 milligram of one vial of ambisome would cost $200. So you can imagine the treatment cost, even if we give in a single dose. I'll come to that. The many preparations became available, but ambisome or liposomal amphotericin B has been used most commonly, and it is now the most popular drug as far as treatment of Leishmaniasis is concerned. So what we did after doing previous trials with a smaller amount of drug over a span of 5-7 days, we did a single dose administration of 5 milligram per kilo of a single dose compared with 5 days treatment, again same dose. And the cure rate was unfortunately 91% with a single dose. Then we tried to increase the dose. And at that time, of course, you can ask me where from you did get ambisome. From the company. Company was interested at that time. So, but we could not improve the cure rate. And ambisome price, you can see that in US today it costs $325 for 50 milligram. In India it's slightly less, about 6,000 to 8,000 for that. Again, I mean, you can imagine one vial costing 8,000 and somebody wants 10 vials, 80,000. From where they will bring this money? Then I just want to introduce you the multi-drug therapy that we did in 2010, around 2010, where we combined ampho-B with either miltefosine or perimomycin, or miltefosine and perimomycin for 10 days. And the cure rate was really astounding. You can see that more than 97% by intention to treat analysis. If you go to the per protocol, it is nearly 99%. It was a very satisfying result, and it augurs well for the future of Leishmaniasis treatment. In 2007, we actually stopped at that time because of the high cost. But in 2007, WHO negotiated the price with the company, and they agreed to supply the drug at 8% of the cost, $16 instead of $200. So this was this changed the entire scenario. And how? Now price decrease made it more attractive. And We had earlier observed a smaller dose could be cure 90%. We picked a higher dose of ambisome for a pivotal phase 3 clinical trial. And we did a randomization 3:1, and the standard was amphotericin B deoxycholate, and single dose means assured compliance, very convenient, and there is hardly any need for hospital admission. In 1 day or 2 days, you can complete the treatment, send back home. The efficacy was fantastic, as you can see, 95.7% with a single dose ambisome, and with deoxycholate classical 96.3%. So very similar. And this actually paper is very important. That's why I'm showing the headlines. This trial became a game changer in the treatment of Kala-azar. Gilead manufacturers, they agreed to donate the drug free of cost to middle and low income countries. That's why, and this program is continuing till 2025, that I know. Probably by then we'll have got rid of VL. And again, in 2013, after we published this study, that elimination strategy was revised, and single dose liposomal amphotericin B ambisome replaced miltefosine for the treatment of VL in elimination program. Then another good thing happened, that as I told you, that now this drug is free of cost to everybody if they want to seek treatment from NGOs or public health sector. What has been the impact? You can see the impact. The numbers were in hundreds of thousands. Now in 2022, we had about 900 patients total all over India. And this year, till 30th November, it was 550 patients. And then Bangladesh could eradicate, and they have achieved the certificate also of eliminated the visceral leishmaniasis, and it was really a very monumental achievement and moment for us. In India also, 633 blocks were affected, except one block. In all 632, the elimination has been achieved. In Nepal, there is some problem with 2 blocks. So, what is the equity now? The rapid test, instead of several days of expensive pathological diagnosis, a cheap and free VL diagnosis in 10 minutes is now available. Everybody, free of cost. Miltefosine again is used for PKDL also, post-Kala-azar dermal leishmaniasis. It's free to VL patients at government outlets. An option of multi-drug therapy is now available, as I told you, and following the development of single dose, which revolutionized the treatment of VL from 1 month to 1 day. And there's massive increase in the capacity of the hospitals. The ice-lined refrigerators were supplied so that even if the power goes for 6 hours, 4 hours, the temperature will not rise. And its adoption in the elimination program, as an elimination program, has helped tremendously in achieving the goal with the excellent tools that we have. Thank you very much for your kind attention.
Thank you very much, Dr. Shyam. That indeed was enlightening. There are a few questions. Before that, may I ask a question? This is about elimination. We are close to elimination. Should we be worried about transmission from patients with asymptomatic infection? And should we be concerned about an animal reservoir in our country, in India?
Animals, actually, we also have done some studies. We did not find any animal reservoirs. We have used dogs and buffaloes and cows. We did not find. Yes, I mean, elimination doesn't mean that we have to lay our guards. There are at least 2 important sources which can cause, as Professor Abraham has told, post-Kala-azar dermal leishmaniasis and HIV-BL co-infections. They continue to harbor parasites for a long period of time. So we have to keep a watch on them. And the problem is that PKDL patients, they don't want any treatment. So we have to convince them and then treat them. And probably we should have a shorter regimen, and we are working on that. Probably we will come out with a shorter regimen very shortly. But this 120 days of 12 weeks of miltefosine is not an ideal one. And plus there are now reports of ocular toxicity with miltefosine. And 1% of our patients developed permanent partial visual loss, which is not acceptable today.
Couple of questions on PKDL. Could nodular PKDL be confused with multiple neurofibromatosis? And second is RK39 useful in PKDL diagnosis?
First question was?
Could nodular PKDL be confused with multiple neurofibromatosis?
No, I don't think. The lesions are very different. And unfortunately, because of the time, I could not show you the pictures. You will find that nodules, they are not hanging out. Their little elevation is there. They are really nodules. So I don't think. And your second question was?
RK39 for diagnosis of nodule.
RK39 for diagnosis cannot be used. It can only tell this patient has got antibodies against RK39 and could have PKDL. But because once patient develops BL, the RK39 remains positive for several years, for years together. So you cannot bank upon the RK39 diagnosis. You have to do a parasitological diagnosis, which is quite difficult, slit skin smear, or what we have recently done is we are using PCR, which is again very effective and have been helping us much in diagnosis.
Is there any attempt for vaccination or immunization against Kala-azar?
We don't have a vaccine. We have 4 vaccines for the dogs, but none for the human. So that shows the importance that they have. For Europe, there are 2 vaccines approved, dog vaccines, 2 in South America, but not for human being at the moment, nothing.
Is visceral leishmaniasis covered under the PMJ scheme, Ayushman Bharat scheme? You said it's free.
Ayushman Bharat will cover everything, but everything is free. There is no need of money.
The last question is about drug pricing. It's highly irrational. Can we do something regarding this? The move to generic preparations and cost reduction using the requirements of the Doha Agreement.
First of all, I think there are many companies now coming out with liposomal amphotericin B, which is available as even 1,200 per vial. But the point is that we have to actually look at the safety and how safe they are, and head-to-head trials need to be done with benchmark, that is ambisome, with the new drug. Then only it can be used. Anything else?
Questions from the audience, Dr. Yogesh.
Yeah. Hi. So wonderful, sir, to hear about the technological developments in both diagnostics and therapy of visceral leishmaniasis. My question is related to actually a mystery that we have in vector-borne diseases at the moment. First off, the fact that malaria is almost getting near eliminated without us doing our jobs well. We know that, I can speak for Central India that we haven't really done much of the vector-borne control programs well enough. And I think the same also holds true for visceral leishmaniasis. So my question specifically is, what is your impression about attributing the near elimination of visceral leishmaniasis at the moment to the technological development that you're thinking, that you are talking about the availability of drugs? I would be more cautious in attributing the near elimination to the technological advance of a cheaper drug than what it was, $16, as you said, or compared to because in malaria, I know there's a resurgence in this year. We have a 35% increase in this year than the previous year, But in visceral leishmaniasis, we know that the data is showing that it is hardly there now in entire Bihar.
The near elimination, the decreased incidence, can you attribute it to better diagnostics and better treatment strategies, or is it something else? Is comparing it with elimination of malaria?
If you don't treat these patients, they are going to die. Okay, and usually there was used to be a natural remission. So I don't think you can attribute it to anything else but to the better diagnosis and better treatment, because it not only cures the patient, it also brings down the transmission. As far as your low-cost drug therapy was concerned, I wish this could happen. There is hardly any interest, even at the moment. There is hardly any interest of the pharma to make the anti-leishmanial drugs.
Attributing, sir, the cure rates and decrease in mortality is something that I think we can do easily to technology.
This is what has been done.
But whether you can attribute the near elimination to the technological advances is the question that I'm asking.
No, at the moment this has been done. The cost is zero. Cost to every patient is zero.
If there are no further questions, okay, one more one. Can VL be confused with Q fever?
I don't.
Okay.
I'm sorry.
Thank you very much, Dr. Shyam. That indeed was encouraging news. We'll wind up this session. Thank you.
I request Dr. O.C. sir to present the memento to Dr. Shyam Sundar.